nephrologist in Canada. He is involved in a number of important activities in nephrology. He is pretty much the preeminent guru in terms of risk prediction in nephrology, having developed the kidney failure risk equation, which is widely used, probably the most widely used risk prediction algorithm in nephrology. He's also an author on the KDIGO 2024 CKD guidelines and is involved in a number of ongoing clinical trials. And today he's going to be talking to us about the role of risk prediction in kidney disease. And of course, many of you will know that risk prediction is coming of age in nephrology. There's now a 1A recommendation that all patients with CKD are stratified or have their absolute risk of kidney failure estimated using a validated risk equation. So I thought no better person to talk about that than the person who not only authored the guidelines but developed those risk scores. So it's really fantastic to have Nav here, and we'll make this recording available to everyone who can't make it today. So without further ado, thank you so much for joining us, Nav, and really looking forward to your presentation.
Oh, thank you so much, Brendan. Can everyone hear me well? Someone give me a thumbs up saying that you can hear me well. Perfect. Love it. Okay, so I'm really honored to be here. Actually, this is probably this is the first time I've given a presentation in Australia, whether it's virtually or real. And it's nice because there's many of you in the room I've worked with, and some folks in the room have done work on KFRE independent of me, which actually is like the most fulfilling, because the best thing about doing scientific work is having your work translated. There's no greater, it hands down beats a New England Journal paper, in my opinion. So maybe I'll start with a thank you for everyone who uses work that we do in some way, clinical or a research perspective. The second perk of presenting in Australia is the time zones. So I get to present at 9:30 p.m. my time, which also means that it's another first for me. I get to have a glass of wine while presenting a rounds presentation, which is like a big bonus. Never had that happen before, so that's good too. So two firsts, and with that, I'll get started. Let's see, here we go. You should see the slideshow mode. So the premise I'm going to start with is that every patient with CKD should be risk stratified, because we have such a common but heterogeneous disease that we should really quantify the absolute risk for each individual. For some people at later stages, it'll be the risk of kidney failure. For others at earlier stages, it'll be the risk of CKD progression. So let's start with that as the starting argument. These are my disclosures. The patient journey for chronic kidney disease patients is largely based on eGFR. Up until the year 2001, the patient journey was largely based on creatinine. From 2001 till 2012, we made decisions based on eGFR, and from 2012 onwards, some of us make decisions based on heat map or albuminuria and eGFR. But that's some of us. The reality is, in vast amounts of clinical practice, certainly outside of nephrology, CKD care is still largely based on eGFR. So what that means is that two people with an eGFR of 30 get the same treatment, two people with an eGFR of 80 get the same treatment, regardless of the risk of progression. So if you're high risk, you get undertreated and you progress. And if you're low risk, you may get overtreated and get costly or sometimes ineffective therapy, and you get all the harm without any of the benefit. We've developed the KFRE. It's now widely used. At actually my last count, the KFRE was accessed, or our website, kidneyfailuerisk.com, was accessed from 192 countries in the last year by almost 200,000 providers, unique providers. So it's widely used, but it really isn't an early stage model. So in earlier stages, care is really one size fits all. And what I mean by that is that most people with an eGFR greater than 45 are not recognized as having chronic kidney disease. The next problem is the burden. So dialysis is like a train hitting you in the face kind of burden. It's very obvious to everyone that dialysis is a catastrophic outcome. So people see it, physicians see it, payers see it. But there's this whole burden starting from earlier stages of CKD all the way down to stage 4 of costs and morbidity from CKD progression and heart failure that's largely invisible. And finally, we have highly effective disease-modifying therapies for CKD. We now have 4 pillars of highly effective disease-modifying therapies, but they don't really reach the highest risk patients, largely because of poor recognition of high risk early on, and also because of an excessive fear about side effects in patients at highest risk. So in fact, there's a total mismatch, and there's nice data on that. So the thesis in my program has been for a very long time that a risk-based approach could transform CKD care. Thankfully, the 2024 guidelines, this is the draft slide from the 2023 draft, but the 2024 KDIGO CKD guidelines agreed and felt that risk prediction is essential to the management of chronic kidney disease. Just want to give a quick reminder before we get into, I'm going to discuss some guideline statements here, because in this talk, I wanted to sort of cover the KFRE, I wanted to cover the guidelines, and I wanted to cover our newer models. So I do want to give this bit of a preamble in the guideline. So I was part of a very hard-working guideline group with representatives from all over the world. And we had a lot of debate about a lot of issues, but ultimately we almost came to consensus on everything. And what drove our consensus was that this framework, this grade framework, that level 1 means we recommend, level 2 means we suggest. And to recommend means that for 80% plus of patients should receive the recommended course of action. Okay, so that's you as a clinician should be doing this for more than 80% of your patients. And in fact, this recommendation could almost be a policy or performance measure. And level 2 is we suggest. That means 50% of the patients could receive treatment A or 50% could receive treatment B. And then there's practice points, and practice points are not in the guideline are not less valuable than recommendations. What they're saying is here's a practical way to implement the recommendation you've just seen. So a recommendation could be, prescribe SGLT2 inhibitors for people with heart failure and CKD. But the practice point could be, start as early as the patient in hospital. Do not discontinue if hyperkalemia, or consider, withholding loop diuretics to enable SGLT2 if volume is a problem. So those would all be the practice points around the overall recommendation of SGLT2 inhibitors. So hopefully with that, I've given you a bit of a framework. So the first thing we want to consider is that in the guidelines, it's very clear that estimation of risk is now an essential part to the approach of diagnosis and management of chronic kidney disease. So here's a figure from the guideline, and I'll highlight some new things. So this is new. Measure eGFR, creatinine, and cystatin if it's available. So the guidelines acknowledge that cystatin C is a better marker of kidney function, of mGFR, when it's available. So do it if it's available. And then this. Stage according to GFR and ACR, that's old. Establish underlying cause, that's old. Estimate risk of progression, that's new, prior to initiating treatment. So the guidelines recommend that you should estimate the risk of progression and accept and account for the heterogeneity for people with chronic kidney disease. So let's start with a chapter where this comes from. Recommendation 2.2.1. In people with CKD stages G3 to G5, use an externally validated risk equation to estimate the absolute risk of kidney failure, 1A. Highest level of evidence, and do it for more than 80% of people with G3 to G5. Now, the guidelines want to be agnostic and appropriately agnostic to the risk equation, but we have to set a minimum standard that an equation has to be developed with good methods and be externally validated in at least an independent population. And then we provide a table. Now, how do you actually do this in practice? These are the practice points. A 5-year kidney failure risk of 3 to 5% can be used to determine the need for nephrology referral, in addition to criteria based on eGFR or albuminuria and other clinical consideration. So 3 to 5%, 5-year risk, or eGFR 30, or ACR greater than 60, or presence of polycystic kidney disease, presence of hematuria, pregnancy, other things. A 2-year kidney failure risk of 10% can be used to determine the timing of multidisciplinary care. This is really a concept that originated in Canada, really nicely shown that this is way superior than using an eGFR less than 30 as the criteria for multidisciplinary care. A 2-year kidney failure risk greater than 40% to figure out modality education, timing for transplant. I'm going to show you some really nice data here on what greater than 40% means. And finally, a prelude to the latter part of my talk. Risk prediction equations for people with G3 to G5 may not be valid in people with G1 to G2. And I would say there's overlap here. G4 to G5, very clearly KFRE, G3B, probably KFRE, G1 to G3A, in KFRE in older adults to rule out disease. Other equations for 40% decline from G1 to G3. So 3 is so large, it's a bit of an overlap stage, but we don't want to use the kidney failure risk equation or equations like it in G1 and G2 for sure. So what are the 4 externally validated equations for kidney failure? It's the KFRE, which has been validated in more than probably 2-3 million people, has more than 100,000 events, highly accurate, highly usable. The Kaiser Permanente model from 39,000 patients, 1,000 events. It's so good that even Kaiser Permanente uses the KFRE. Martin Landry's model from CRIB and East Kent cohorts, 595 patients, and the Z6 score from the German CKD study. So these are the 4 models that the guidelines recommended you should choose from. So let's start with the KFRE. So I think this is all familiar to most of you. The KFRE has been validated in Australia. It should be used in Australia, and I think is used in Australia in some care settings. It's used in surprising number of places. The most random place I can think of is New Caledonia, where there's a French version of the KFRE website, which was built several years ago. Here's KFRE versus eGFR for decision making. This is a graphic from the guideline. So eGFR 30 to 60, usually used to transition from primary care to nephrology care, make that kidney failure risk greater than 3 to 5% over 5 years. eGFR less than 30, transition from nephrology care to interprofessional care, make that kidney failure risk greater than 10% over 2 years. eGFR less than 20 used to be access and transplant planning, make that kidney failure risk greater than 40% over 2 years. So what happens if you actually put this into practice? Like, what's the natural experiment? So thankfully, a lot of this work has been done in Canada and to answer some of these questions. So this is a nice study done in Ontario, and I'll show you similar data from a study done in Alberta, Canada, where what they showed was in Ontario, Canada, and in Alberta, Canada, they used to follow everybody with a GFR less than 30 in a multidisciplinary CKD clinic. So these patients would get a fairly extensive care bundle, which included a nurse, a dietitian, a pharmacist, a nephrologist, multiple visits a year, very costly but intensive. And in 2016, these provinces both switched to a KFRE threshold of greater than 10% over 2 years. Now look at the patients who are discharged with a low KFRE from these clinics. Over a period of 397 person years, less than 4%, 2 to 4% actually develop kidney failure in the future. So it's very safe to discharge people from these clinics to a nephrologist, not just discharged in the primary care, from multidisciplinary care to a nephrologist. Hardly anyone is going to develop kidney failure. Same thing in Alberta. Okay, so here's 1,100 patients. 1,300 patients, 1,100 who said, stay in the clinic, your KFRE is high. In 1 year, 295 start dialysis. Do not stay in the clinic, go just to a nephrologist. Within 1 year, 1 out of 176 started dialysis. Your risk is so low, you can just go to your PCP, 0 out of 58 started dialysis. So when we implement the KFRE to triage and determine nephrology care in late stage to kidney disease, it's safe, it's effective, it prioritizes people who need that multidisciplinary intensive care. Now let's put this on time. This is kind of new data from Chi Chu, who's done some really great work validating the KFRE in different cohorts, relating it to time. This is data from UCSF. Really nice slide here with 2 panels. More wine. So first on this panel is the KFRE, and this is months to kidney failure on the y-axis and KFRE on the x-axis. And these are the 95% confidence intervals. Here it's eGFR on the x-axis and months to kidney failure on the y-axis. What I want to point your attention to here is that the bands, the confidence intervals are a lot wider for eGFR or KFRE. So for a given KFRE threshold, the 75%, so the interquartile range, or the 95% confidence interval of time to dialysis is always going to be narrower than eGFR. So how does this translate into real numbers? If someone's 2-year risk is 10%, on average, that person has 5 years to go to kidney failure, with an interquartile range of 30 to 104 months. If you set that threshold at 20%, it's 43 months, and this is the fistula threshold. If you take everybody at 40% or higher, at 24 months, half of them will be on dialysis with an interquartile range of 12 to 41. So that's kind of the right time to start talking to them about access and planning. If you think you can get an access in pretty quickly, you could probably go to 50%. And then your median is 18 months with an interquartile range of 9 to 32. And of course, for really, really intensive decisions, so now you're talking about like putting in bedside catheters for peritoneal dialysis and things like that, really you're thinking about 80% at 2-year risk, which is 4 and 14, right? 8 months at median, 4 to 14 months as the interquartile range. When you do this, when you add KFRE thresholds as the primary decision makers for dialysis planning, this is data from BC published in KI reports with Adira. More people get a fistula before dialysis, so 58%, and less people get a futile fistula. So 49 versus 58 for eGFR and 31 versus 58 for eGFR. So not only do you get more appropriate fistulas, you get less inappropriate fistulas. So for these late stage type decisions, the KFRE can be really quite helpful in helping guide that pieces of nephrology care. So how do you implement it? So in my view, the best way to implement an equation like the KFRE is the lab. And the reason I say this is because it's a lab-based equation. And when you deal with a lab, usually labs are large and they already have a pipeline into the electronic health record. And so you don't have to deal with different electronic health record vendors and different versions or instances of different electronic health records. Nonetheless, people have managed to get it into Epic, which is the dominant EHR in the United States and in Canada now. So this is a visualization from the Johns Hopkins EHR for KFRE. It shows for every patient with kidney disease, what's their 2-year risk, what's their 5-year risk, and it shows whether they're on ARB, SGLT2, MRA, GLP-1, or ACE inhibitor. And it shows the timeline. So you can almost see why something was started and stopped, and perhaps you can even flag a reason as to why. So why are we doing all of this? Well, we do all of this because what we're trying to do, why do we have these 5 drugs here, is because we're trying to reduce the risk of kidney failure, right? That's what we're ultimately trying to achieve. The KFRE is helpful a lot in planning, and it can help give these really on the website. They can tell patients who are later stages that it's still time to act, because even if your 5-year risk of dialysis is 28%, with multiple therapies, you can probably get down to about 10 to 15%. And I've just highlighted finerenone here because that's our most recent addition to the site, but we will be adding semaglutide as it gets added to the guidelines. So that's the update on KFRE. Hopefully that gives you a fair bit on work we've done and the newest things, and hopefully the timelines are helpful. So the next question becomes what to do in earlier stages. So you have a 50-year-old male with diabetes with an eGFR of 80 and about a gram of albuminuria. If you use KFRE, this person's 2-year risk is 0.07% and 5-year risk is 0.2%. But in fact, they're high risk. Their CKD progression risk is actually 10% over the next 3 years. And the reason for this mismatch is because it's the wrong outcome. Dialysis is the wrong outcome for someone with a GFR of 80. you really need to think about a different outcome. And you really need to be thinking about outside the heat map, right? If you look at heat map boxes, there's 40-fold variability in KFRE risk between heat map boxes, and there's 80-fold variability in 40% decline risk in people in the same heat map box. So that means someone, for example, who's G2A3, so GFR 60 to 90, but lots of albuminuria, two people in that same box can have a risk that varies by up to 80-fold. And to me, that's not enough to know that someone's in an 80-fold box, especially when we can get much more precise. So borrowing a slide here from Brendan, Vlado, and lots of colleagues, we do this because we want to intervene early because intervening early matters. So this is our G2A3 patient, right? If you wait till G4, even with the best therapy, you can make that patient's time to kidney failure go from 73 to 76. But if you acted early in G2A3, you could make that patient go from 81 to 92. So that's the promise of finding high-risk patients early and treating them early outside the box. So what are we doing today? Today, we are not treating those people any differently, right? So patients are not recognized till they're 30 to 45. Majority of kidney function is lost. Highly effective therapeutics cannot be started. So this is data I collected from 7,000 patients in primary care practices. And what we found was that high-risk patients were actually less likely to receive statins, RAS inhibitors, or SGLT2 inhibitors compared to low-risk patients. And I can replicate this in the well, I did replicate it, but others have replicated it in the VA cohort. We replicated it in the Optum cohort. High-risk patients actually are less likely to receive effective therapy. It's shocking because we don't see risk. Physicians largely just see EGFR. So we wanted to answer this question. We wanted to answer the question, who with early stages of kidney disease will develop progression? So we developed new models for patients with CKD stages 1 to 5. We call them the ClinRisk model, K for kidney, ClinRisk for clinical risk prediction. And these models predict the composite of 40% decline in GFR or kidney failure. Sticking to our theme, sticking to our strength, we wanted to build using routinely collected lab data. So these models are based on a CBC, a metabolic panel, and a urine ACR. No biomarkers, no EHR access, accessible through the lab, really models for everyone. We started out in 2021 in 77,000 people in Manitoba, Canada, validated in 100,000 people in Alberta, Canada, validated in Canvas, in Credence, in Fidelity, in 4.6 million people with Elevance Health, one of the big US health insurers, and we linked validation to cost of care in Optum Labs in 1.1 million people. Total sample size, 5.8 million adults, in which we've validated this model and shown that it's consistently accurate and more accurate than the standard of care. In the first validation, AUCs were 0.84 to 0.88 at all time frames, and they've largely stayed, I shouldn't say largely, almost exclusively stayed above 0.8 across every single cohort we've developed, whether it's been a clinical trial or whether it's been a general population sample of like 5 million people. So let's start with an overview of this. Canvas and Credence, comparing the ClinRisk model to EGFR and ACR, or the KDIGO heat map, or the KFRE, AUCs 0.81 to 88 versus 7.4 to 8.3. So an AUC difference of about 0.05 to 0.07, which is actually very large once you get near 80%. It's very easy to move the AUC at about 0.6. It's very hard to move it at around 0.8. Not only that, we see a 30-fold separation in risk between high and low risk groups. We see a change in drug and placebo risks over 6 months. In just 6 months, we see a 20% change. The drug group's risk drops by, decreases by 5%. The placebo group's risk increases by 13%. So it diverges. It follows all the face validity of what we saw in the trial. So now showing one of Brendan's slides from the SMART-C. What are the absolute effects of SGLT2 inhibitors? Let's start with the importance of risk prediction, okay? So this is a slide that was shown, I think, by Will Harrington and Ali Staplin when they presented the EMPA kidney data. And they said that for 1,000 patient years, you prevented 11 kidney disease progression events, 11 CV death events, 4 kidney failure events, 15 kidney disease progression events for non-diabetes. Really incredible data per 1,000 patient years, right? So I'm a big believer in these drugs. Absolutely believe these numbers. I don't question them ever, right? However, what I would say is that for the 11 events that you're preventing, right, for kidney disease progression, I would challenge that in high risk people for 1,000 patient years, it's probably 110 events that you're preventing. And in low risk people, it's probably 10 or 2 events that you're preventing. So my view is that this is true for the entire spectrum of people with or without diabetes, but there's vast differences in the absolute efficacy or the absolute benefit for each of these drugs, depending on your baseline risk. So let me show you some of that data. This is data of a paper we just published from Canvas and Credence with the investigators and the steering committee. High-risk patients, as per the ClinRisk model, had an eGFR slope of negative 5.7 on RAS inhibitors alone. With SGLT2 inhibitors, their GFR slope dropped to minus 2.8. They had a net benefit of CKD progression of 3 mils per minute per year. Intermediate risk patients had a net benefit of 2 mils per minute per year, and low risk patients had a net benefit of 1 mil per minute per year. So again, everybody benefits, but the degree of benefit is spread along the baseline risk continuum. So now you may ask me that that's just the slope benefit, and that's not the only thing these drugs do. What about the combined cardiorenal benefit? So I'm going to preview one note from a recent abstract that Emily Leung, I think, and Brendan worked on. The number needed to treat for the combined cardiorenal outcome in the same population per our model is actually 5 for high risk people. And I think it's about like 100 for low risk people. So whether it's the eGFR slope or the combined cardiorenal outcome, the distribution along risk continuum really holds. When you look at risk and slope, abundantly clear, like even 2-year slope, patients who are low risk have a not a very steep slope, about 1 mil per minute. Patients who are high risk, very high slope, about 5 mils per minute. It's natural. Risk is associated with slope. So knowing someone's risk can give you a window even in what they're going to do in the next 2 years. Why does this matter? So it doesn't matter for the people who are A3B or albuminuria more than a gram per gram, right? If you have somebody in your clinic who's got more than a gram of albuminuria, they are high risk. You don't need a model to tell you they're high risk. But for everybody, and for the vast majority of people who are less than a gram, there's a lot of variability. What we found in work that we did in Canvas and Credence was that 1 out of 4 people with minimal of no albuminuria were actually high risk and had the same or higher event rate than people with 300 milligrams per gram to a gram of albuminuria. So imagine the vast majority of people that have CKD that are less than a gram of albuminuria per gram of creatinine. Only 1 out of 4 of them are really high risk, and the other 3 to 4 are lower intermediate risk. However, when you map that out to the US population or to the Australian or Canadian population, these people are like 6 to 8 times more common than people with more severe albuminuria. So what we're trying to say is that there's just as many people with low albuminuria who are high risk, who have the same event rate, who should be included in clinical trials of CKD progression than people who are enrolled based on albuminuria alone. So make these trials more inclusive, include these people with lower albuminuria who are actually high risk. So just one example of how the applications of risk prediction can stretch far beyond clinical care. A second clinical trial here, so data from Fidelity, major difference between KDIGO, so eGFR and ACR versus ClinRisk, 0.59 versus 0.81, 0.66 versus 0.86 for C statistics. And again, really beautiful calibration. And what you can see here in Fidelity, so in Fidelio and Figaro, there were patients who had a 0.1 to 7.7% risk of progression over 2 years, and there were patients who had a 31 to 81% risk of progression over 2 years. So what you see in the clinical trials is what you see in clinical practice. There is 80-fold variability in people who are even included with the same inclusion and exclusion criteria. Ending the clinical trials data and going on to the general population. This is data from Optum, looking at 1 million people stratified by risk. So big separation, high risk people do very poorly. In fact, high risk people have a 10 times higher risk of progression than low risk people, 4 times than high risk people. And this carries a decade out, not just 1, 2, and 5 years. If you have long enough follow-up, almost half of people in the high risk group would have progressed in 10 years. So this is really important if you think for a pair like the Australian or the Canadian healthcare system, where horizons are longer than 2 years, right? In the US, everyone only cares about 2 years. People are leaving their health plans consistently. But in the countries where we work, you know, the government or the single payer is responsible up to 10 years or 25 years out. So this is important that when we label someone as high risk, their poor prognosis continues to follow. And this is the point about baseline use. In high risk people, both SGLT2 and GLP-1 agonist use is lower than medium or low risk people. So we just see this everywhere. Discontinuation rates are higher, initiation rates are lower. We don't tend to do the right thing for high risk people. When you compare in Optum KDIGO heat map to the ClinRisk risk group, what you see is that the algorithm is sensitivity optimized. Cases are consistently moving up. So 52% of cases move up, only 3.2% of cases move down. So it's sensitivity optimized. It'll find the people who are going to progress. Another break. Okay, zooming out even bigger. So we did 1.1 million people. We showed 10-year data. We talked about progression risk. What about costs? So this is data from 4.6 million people in the US looking at, does the algorithm predict costs of care? So it turns out it does. When you compare high risk to low risk people, there's 3 to 5 times more all-cause costs, 13 to 30 times more CKD related costs, and it's all driven by inpatient visits and ER visits. When you look at younger people or older people, so commercial is younger people, Medicare is older people, what you see is that at baseline, the inpatient stays, so this is inpatient stays per member per month, are not that different between high risk and low risk people, 0.13 and 0.10. So if you just looked at historical utilization, there would only be a 30% difference between high risk and low risk people. But when you look 2 years out in follow-up based on the model prediction, that difference is 350%. The high-risk people have a per patient per member stay at 0.14, low-risk people 0.04. And what is it all driven by? It's all driven by inpatient utilization. It's almost all drugs. It's almost all hospitalizations. It's not really drugs. It's all driven by heart failure events and CKD progression. And what you see on this slide is that for the low risk people, it really doesn't appear to change very much at all. And in the high risk people, it's not only is it driven by utilization and inpatient utilization, it's largely driven by CKD related costs. These are blue bars showing that CKD progression means CKD related costs. That's not just true in the US, that's true in Sweden, in Japan, in Canada, in the UK. We've done the study in 14 countries. Costs for patients with CKD are driven by CKD and heart failure. So this is hospitalization events per 100 patient years. You can see CKD and heart failure together is 25. Stroke, MI, peripheral arterial disease is 9, right? So our patients tend to have cardiorenal events, and we're fortunate that the drugs we treat with, which are RAS inhibitors, SGLT2 inhibitors, finerenone, treat cardiorenal events, right? So when you select somebody who's high risk and you choose to treat them, you're likely to have a cardiorenal benefit, not just a renal benefit. So the next point in the last 10 minutes becomes, how do you actually make any of this happen? So we are making this happen. We're making this happen with the largest lab provider in Canada. So we were able to integrate and commercialize this test with the largest lab provider in Canada called Life Labs. And this is a sample of an actual report from an actual patient. So this patient has a 60% risk, very high. 60% of the circle is red. 60 out of 100 stick figures are red. And it describes that it's the risk of up to 40% decline in GFR. So that's one piece. This patient is high risk, needs to be attentioned, okay? And the next piece, we give the primary care doctor a comprehensive report. Please monitor this patient 3 times a year, target a blood pressure of 120, refer them to a nephrologist, treat their anemia and acidosis, and treat them with RAS inhibitors, SGLT2 inhibitors, and MRA. We map all their labs to clinical practice guidelines, and we provide recommendations that are evidence-based and product monograph-based. So nothing is off-label, nothing is off guideline. Really what we're trying to do is provide an e-consult in a test for high-risk patients and empowering and encouraging non-nephrologists who look after the vast majority of kidney disease to deliver the same quality of care that the best nephrologist would. A few slides and some additional work, and then I want to wrap up. So I also worked on the CKD PC models for 40% decline in GFR. These have also been externally validated in 1.6 million adults across multiple cohorts. Unlike the ClinRisk model, which only uses labs, the CKD PC models require blood pressure, antihypertensive medication use, history of certain conditions, insulin use, and oral diabetes medication use. As such, they really require electronic health record and claims data in addition to just lab data. We have built models to predict mortality, quite simple ones: age, sex, GFR, ACR, hemoglobin, and albumin. The problem is that models to predict mortality are never accurate. All-cause mortality is very hard to predict. And so it's my view that you should never use an all-cause mortality model to make any decision about futility or not planning for kidney failure. All you should do is maybe identify a group of patients that may have an earlier discussion of conservative care pathway, but there's no chance that your all-cause mortality model is accurate enough that you would withhold fistula planning, transplant planning, or any other decision based on this prediction. It's going to be wrong 30% of the time. One plug for a cool model that I did as a project with urologists called the kidney cancer risk equation. So I used to see consults for patients with kidney cancer. Hopefully some of you in the crowd can relate. Patients with kidney cancer face a dilemma. Do they get a partial nephrectomy? Do they get a radical nephrectomy? Or do they do watchful waiting? And the concern about impending kidney failure is actually influential in their clinical decision making. It really matters to them. So what we did is we built on the KFRE and we did age, sex, GFR, ACR, diabetes, and the type of nephrectomy. We developed in one province in Canada, validated in Ontario. We are working with, I think, Robert Ellis from Australia, who's a person who's previously published in this, and validating in 6 other countries altogether. This is already available at kidneyfailurerisk.com. What we want to try and do is show that in multiple countries, multiple healthcare settings, we can predict your future risk of kidney failure before you have that partial or radical nephrectomy, or if you choose watchful waiting. The last 2 minutes, what I want to say is that CKD is staged by a combination of GFR, albuminuria, and cause. We should continue to do this. This is unchanged. But staging is only the beginning. Risk stratification has to follow. We have to estimate the absolute risk for every single person with kidney disease. And for later stages of kidney disease, you can do this today at kidneyfailurerisk.com. The models are available, they're accurate. We continue to add the tools that you can use to describe risk to your patients. For earlier stages, we now have new models that can highly accurately capture the risk. And why do we do this? Because high risk patients need high intensity therapy. And how do we overcome clinical inertia in treating these people? Why are these people not treated till GFR of 30 to 45? It's because every patient with multiple risk factors that are slightly out of range looks good in the clinic. We don't want to rock the boat. Virtual visits make it even harder. It's harder to start a new medication, start a new treatment on a virtual visit on the phone. We have to acknowledge that we cannot compute multivariable risk intuitively. As much as we think we can, it's very difficult to do. We can find the extremes, but we cannot find the entire middle. And to me, when disease modifying therapy is available, when highly effective 4-pillar disease modifying therapy is available, absolute risks can help us frame the conversation. It can help us have an intelligent discussion of benefits, risks, costs, individualized to the person in front of you, not to 1,000 person years, not to a box in the heat map, and not to a recommendation in the guideline. It can make it front and center directly to the person you're speaking with. So with that, I'll wrap up and happy to take questions.
Thanks so much, Nav. Sunil, Kathy, and Ivo, I saw your questions, but being parochial as I am, I might give my own colleagues the first opportunity to ask any questions if they have any. Does anyone in the room have any questions for Nav?
I was going to make more of a comment that like our pharmaceutical regulatory systems really work around EGFR and albuminuria. Have you persuaded yours otherwise?
Sorry, to order EGFR and albuminuria?
No, which drugs we can prescribe are really based on EGFR and albuminuria rather than on a risk profile.
So I think that, my view is that EGFR albuminuria kind of give you a starting point, but just in that entire range up to about 1 gram of albuminuria, there's just still too much heterogeneity for me. And I think that I see people, and our data shows people under 1 gram who have, like, one person could have a very high risk, another person could have a very low risk. So I'm much more of the belief that we need to get, yes, the guidelines are, targeting based on albuminuria, but I think when you're having a conversation with an individual person, you can confidently say, if your predicted risk is 30% and the trial had a hazard ratio or a relative risk reduction of, let's say 0.6, your risk will drop to 18, right? So that's, for me, those kind of conversations are really helpful in making decisions around absolute risk, if I understood the question appropriately.
Nav, there's a question from one of our nephrologists at St George Hospital, Kathy Lane. She has asked about how the drugs or the use of some of these guideline-directed drugs affect kidney failure risk. So if you have a acute drop in GFR with an SGLT2 inhibitor or finerenone, at what time point do you re-estimate risk, and does that drop in GFR kind of muddy the water in terms of reassessing their risk of kidney failure?
Yeah, I think, it's an excellent point, Kathy. I think for KFRE, this is a bigger issue. And at first, I would re-estimate after about 6 months, ideally, when the dust is completely settled. But for KFRE, this is a bigger issue because EGFR is a fairly sizable contributor to KFRE. For the ClinRisk models, ACR is a much, much bigger contributor than EGFR in terms of relative weight in the model. And so it doesn't seem to have the same effect with albuminuria reduction. It does unfortunately turn out that patients who have large drops tend to have a worse prognosis. It's not because of the drug. They still benefit from drug versus placebo, but there's been nice work showing that, a patient who has a big drop in eGFR from either RAS inhibitors, SGLT2 inhibitors, or phenone, actually it's just a marker of worse prognosis. So unfortunately, that patient is not going to do great, but you're still doing them a favor by starting them on therapy. All you've uncovered is that they don't have a great prognosis.
There's a question now from Sunil about the competing risk of mortality and how the KFRE doesn't necessarily take that into account. Do you want to address that?
Yeah, so every few years we try to tack this issue sort of head on. The most recent validation, which Morgan Grams led, and it's published in JASN, I think last year, we systematically looked at the competing risk issue across 59 cohorts. And we developed a competing risk version of the KFRE, and we compared it to the original equation. And the reality, unfortunately, is that accounting for competing risk improved calibration in about half the cohorts, and it made it worse in the other half of the cohorts. So we could not find a consistent advantage of including a competing risk framework in the model, right? So yes, there is a competing risk for death, but does accounting for it make a prediction more accurate? I disagree that it does consistently. And in the prediction business, actually, so this is the philosophical thing, right? Like in the prediction business, you want to make the most accurate prediction. Whether you, like, for example, I give a silly example, like let's say troponin is on the causal pathway to CKD progression. It's actually causal, but ALT gives you a better prediction, right? You would choose ALT because you want to make the better prediction, right? Or you would, so the prediction literature is much more concerned with making the best prediction than doing things that are methodologically, competing risk or finding things along the causal pathway. When we tell you that something is in the KFRE or something is in the clinical risk model, we're not telling you that if you act on this biomarker, that this is the causal effect, that you treat this, the risk will drop, the outcome will improve. We're focused on making the best prediction for each individual patient.
And Nav, we have a question from Ivor Katz. You might know Ivor because he's done a lot of work with Kidney Health Australia, especially primary care and the use of the KFRE to triage nephrology referrals. He's asked a couple of questions, which you can see probably in the chat there. But the first is about how solid is that data on 40% risk of kidney failure over 2 years and access placement? He's reviewed data from his centre that suggests that, yes, it's good and accurate, but perhaps may lead to an over or unnecessary access placement, and maybe a higher threshold should be used. I don't think we're particularly using a risk-based approach to plan access at the moment. So maybe your comments on that.
Yeah, so very much we actually debated this at the ERA Journal Club a couple of weeks ago, and really consensus was very much the same to Ivor's point, and thank you, Ivor, for doing like such great work on KFRE in Australia, is that it really depends center to center, and you should use, we kind of recommended a range in the guideline text of 30 to 50%, acknowledging this. Like it says 40% in the main headline, but underneath the text in the fine points, it says, 30 to 50% may be appropriate for different settings. The data I showed is from CKDOPS, which was sort of the, fairly representative data across multiple countries, but that doesn't mean that it's representative to your center, right? So I would say in general, KFRE-based thresholds are going to be superior to EGFR-based thresholds, but the best threshold for your center depends on actually how quickly you can get access. Like if you need 3 attempts and the surgeon's really crappy and there's a long wait list, you may want 30%, right? But if your surgeon's really good and you can do it immediately, you may want 60%. So I think you have to take all of that into account.
Ivor, did you want to make any comments or?
No, that's great. I mean, that second half of the data we're hoping to publish soon from our experience. But yeah, you're right. We can get access in within a year of the GFR being around 10. So it is different in Australia. I think most centers can do that. So hopefully we found like KFRE more than 65% probably predicts when we need to put in the access.
Are you guys super fussed about like fistula first? That's also a big factor, right? Like if you think about US, but like in Canada, for example, like if someone, there's almost an equal emphasis on futile access than there is on having a fistula in. Whereas in the US, a futile access is not such a big deal, but missing a fistula is a very big deal. So all these things I think weigh in how you decide on what your threshold should be.
Yeah, no, we want to get it in. So 40% was good to get the education done, but to actually put fistula would have probably resulted in sort of excess fistulas, which we would have had to then track and monitor, which doesn't make it worthwhile.
Yeah, thank you. Thanks for that. I look forward to that paper. Thank you.
Okay. Any more questions from in the room or online?
I see a couple more. Yeah, go ahead.
Can I just ask the second question? Is again from that same paper, which I loved, where you had that GFR comparison, the pro versus con paper from 2017. Yeah. That 10% group that fits into the transition to nephrology and interprofessional care, it's a big group, and there's a lot of overlap between us and the GPs. And in truth, the reality is that group of people probably should be managed in primary care. So
in
how
our
do we
center,
really
we
tackle
use
that
20%. In our own center, we use 20% because we don't have enough staff to do 10%. So that's my answer. You know, it's again, it's sort of a local. You do what you do what works for you. So I would absolutely echo that for sure.
Thanks.
Just a question about cystatin. So there was a nice abstract presented at the ERA meeting from Patty Mark and Juan Jesus and UK Biobank and SCREAM, where the SCREAM has a lot of cystatin in Stockholm, and no difference in accuracy with KFRA, whether you use creatinine, cystatin, GFR, or creatinine GFR. So it doesn't appear to matter. Question about older. Yeah, sorry.
Yeah, no, I was just going to comment that we have an interest in a strong supportive care service, and nephrologists like Amanda Sirudana and Sarah Roxburgh who do a lot of care of the elderly. And Amanda had a question about the accuracy and validity and use in elderly patients.
Oh, so that's an excellent point. So Amanda, this kind of comes down to the competing risk problem, right? Like, so where is competing risk actually a problem? So the competing risk is actually a problem where it overestimates risk in people who simultaneously have a very high risk of mortality and a very high risk of kidney failure. So when we look in 59 cohorts, you don't see a consistent advantage at all. But where I think you would see it is if you focus down to people in their 80s who had kidney failure risks more than, say, 20, 30, 40%, right? Over 2 years. So kind of the people that Ever was talking about. So in those people, probably because that competing risk is quite high, you may be slightly overestimating the risk, and maybe you use a cutoff of 50% or 65% in those people instead of 40. Unfortunately, when you design an equation for general population use for the vast majority of people, there are going to be spots where it cannot be ideal for every single scenario. And the one scenario I think where competing risk really does count is people in octogenarians who simultaneously have a very high kidney failure risk and a very high mortality risk.
Okay, Nav, well, thanks so much for joining. Was there another question?
Good. No, I was just going to say, that's great. I feel like competing risk is such a tricky thing in this population, so thank you.
Yeah, thank you.
Thanks, Amanda. Well, Nav, thanks so much for joining us late, and hope you get to finish your glass of wine later tonight. And it's amazing to see risk prediction really becoming, standard of care in the guidelines. And I think you showed that the application goes way beyond clinical care and perhaps even into clinical trials. So I think this is going to be a really interesting time. And so thank you so much for joining us.
Thank you, everyone. Really loved it. Thank you so much. Take care.